The main causes of the disease are, of course, carcinogenic related causes, which are alcohol and tobacco use, and excess, of course, in tobacco and alcohol. But lastly, HPV positive head and neck cancer patients were seen, so it has been seen that HPV is may be associated with some subsites, tumor of some subsites namely of oropharyngeal cancer origin. So these new features, these new problems that are arising are a little bit changing the cancer patient populations that we are seeing. Those patients are younger, mostly non-smoker, non-alcohol drinker, and this is probably a sexual related disease. So, but a lot of work has to be done in this direction to sort out how to cure them in the best way. First of all, I have to make a disclaimer. I'm a medical oncologist, so probably I'm a little bit biased in relation of neoadjuvant chemotherapy. I've been involved since many years in research, including neoadjuvant chemotherapy. So what we have in the literature from the last meta-analysis is that induction chemotherapy is not as effective as concomitant radiation. Anyhow, it's not detrimental. It has a marginal, probably a marginal effect. It has an effect on distant metastases. The most important thing, I think, for which we should use neoadjuvant chemotherapy is probably for organ preservation, for laryngeal cancer, advanced selected laryngeal cancer. So I think that neoadjuvant chemotherapy has a future. We still need to have the results included in the meta-analysis of the taxane-based triple neoadjuvant chemotherapy, which were not included in the last meta-analysis, which showed only a marginal effect of chemotherapy. Of course, TPF or taxane-based PF are better than PF alone. I think that we are facing a very fascinating future for these technologies. I'm a medical oncologist, so I'm not used to speak about things that I do not know in deep. What I can see is that radiation therapy is taking really new trends, and this will help our patients mostly in avoiding late sequelae and toxic effects, which is the most important part of the story. So I'm starting always from the point that head and neck cancer patients are curable patients. So if this is the case, then we should take care about their quality of life. And in this sense, all these technologies will help in reducing late effects of chemo, radiation, or both of them, so that they can live can go back to their life as soon as possible. I think that this is a lifestyle in your profession. So what you have to do is really to have a step back and to listen to the other professionals and to the other experts in the fields, and then you have to cooperate with them together, probably also with the patient, so that he can be aware of the decisions that has to be taken for him. I would say that the guarantee for the best cure for these patients is the fact that the multidisciplinary group is taking care about first of decisions, of treatment decisions and then of the whole treatment plan. So only if this is in place in hospital institutions, this will probably succeed in a better cure rate. So the ideal form of how to interact in this way can be very different. In some hospitals there is the facilities, a multidisciplinary group is already settled, and the patients can come in and have a multidisciplinary first evaluation. In other hospitals, I think that much work has to be done in this direction. Why not using informatics to help those people being seen by different experts?